Hello, and welcome to our 6-part series on back pain care. The purpose of these videos is to present a standard, evidence-based approach for managing patients with back pain in primary care practices at UCLA. The videos have been designed to ensure that patients receive high-quality care while reducing unnecessary imaging. Another goal of these videos is to decrease unnecessary specialty referrals for the majority of our patients who have nonspecific back pain that is likely to resolve with conservative management. In this video, we'll discuss indications and timing of referral for patients with back pain who do not respond to management in the primary care setting. There are 3 branch points for possible referral: 7 to 10 days after initial presentation with acute pain, 4 to 8 weeks after initial presentation with acute pain, and 3 to 6 months after the initial presentation of acute pain, which can be considered chronic pain. Remember, the majority of patients with low back pain will not need referral. If the imaging tests reveal abnormal findings such as cauda equina syndrome, cancer, or osteomyelitis, patients require imaging urgently and immediate referral to the appropriate provider. Patients with radicular symptoms and motor weakness, such as foot drop, also need urgent imaging and referral. However, 85% of patients with back pain have either acute or chronic nonspecific back pain without a specific etiology for their symptoms. This video presents a framework for how to think about referral for those patients who continue to have back pain. As described in video number 3, patients with initial presentation of acute back pain should have a 4-part conservative treatment plan for 7 to 10 days, including advice on specific positions to relieve their pain, movement exercises for patients with intermittent, not constant pain, treatment with acetaminophen, NSAIDs, and/or muscle relaxants, and application of ice or heat. These patients should be scheduled for a repeat visit to the primary care provider to reassess their symptoms in 7 to 10 days. After 7 to 10 days, there are 3 main points to consider. Patients whose pain is at least somewhat improved and are able to cooperate with the physical therapy requirements can be referred to physical therapy for a 4 to 6 week treatment regimen. Patients who continue to have severe pain without any improvement can be referred to pain management or physiatry. As patients with sciatica may take longer to improve, consider waiting another 7 to 10 days to ensure that they are not going to get better with the initial treatment plan before referring for urgent management of severe pain without improvement. The second branch point comes between 4 to 8 weeks after initial presentation. Patients with back pain who have not improved after the initial treatment plan and have not improved after a course of physical therapy should be seen back in the primary care provider's office for reassessment at 6 weeks after initial presentation. It may be helpful at this point to discuss the case with the physical therapist that saw the patient in care, who may have some helpful insights into why the patient may not be improving. At the 4 to 8 week time point, patients who continue to have nonspecific back pain should have an AP and lateral lumbar x-ray. If the x-rays are normal, options for referral include physiatry at the UCLA Spine Center, pain management, acupuncture at East West Medicine, chiropractic services, and massage therapy. The medical literature suggests that patients experience the most benefit from treatments that they believe will work, so a discussion with the patient about their wishes and interests is helpful prior to placing the referral. At the 4 to 8 week time point, patients who have ongoing radicular signs or symptoms suggestive of a herniated disc or spinal stenosis should have an MRI. If the MRI shows abnormalities suggesting either of these conditions that correlate in terms of location with the history and physical exam, those patients may benefit from referral to either physiatry at the UCLA Spine Center, pain management, or spine surgery. Patients who are not interested in surgery should be referred to either pain management or physiatry for possible non-surgical intervention, which may include epidural steroid injections. The third branch point is at 3 to 6 months after initial presentation. If you and your patient have reached the third branch point in the referral pathway, here are some considerations to keep in mind. Patients with nonspecific acute back pain for 3 to 6 months or more are considered to have chronic back pain, even if it is their first episode of pain. An important consideration for patients with chronic back pain of 3 months or more is spondyloarthropathies such as ankylosing spondylitis. Patients with historical features or findings on exam or imaging that suggest a spondyloarthropathy should be referred to rheumatology. These patients should have an AP pelvis X-ray, an HLA-B27 lab test, an ESR, and a CRP ordered at the time of referral. In the majority of cases, if the back pain has lasted for at least 3 to 6 months without an obvious anatomic cause, it is very likely that there are contributing social and psychological factors such as anxiety, depression, or substance abuse playing a role. Other potential contributing factors include being overweight or obese, deconditioning, and lack of physical activity. A comprehensive approach to management of these patients is addressed in a separate video, which includes considerations of other causes for back pain originating from retroperitoneal structures or from the sacroiliac joints. The preferred treatment approach centers around identifying and treating psychological issues, as well as identifying a combination of supportive treatments and strategies for chronic pain that can help the patient cope with pain symptoms. While this management plan for chronic pain of 3 to 6 months or more can be developed in the primary care setting, there are also several options for specialty referral that may be helpful. These include the pain management service, who have experience with many types of complicated pain syndromes, as well as physiatry at the UCLA Spine Center.